Welcome back to the Deep Dive. Today, we are stripping away the safety net. We aren't just exploring a topic, we are entering a simulation.
That's right. Today, the stakes are significantly higher than usual.
I want you to visualize this. You are an MD anesthesiology postgraduate student. You're sitting in the hot seat. It's the final practical exam for Gujarat University. The air conditioning is humming, your palms are sweating, and the external examiner is, staring at you over the rim of his glasses. The case on the table is bronchial asthma.
And I'm stepping into the role of that senior faculty member. I'm the internal examiner sitting next to you. My job today isn't just to teach you the facts, it's to guide you through the minefield. I'm here to point out the traps that fail candidates and the precise gold medal answers that distinguish the consultants from the students.
Our mission is to take this massive stack of source material we've compiled, standard texts like Miller, Morgan, and McHale, Guyton for physiology, Harrison's for medicine, Robbins for pathology, and K.D. Tripathi for pharmacology, and distill them into a single, cohesive, exam-winning narrative.
We're really covering the full spectrum here.
Oh yeah, from the cellular level of inflammation right up to the terrifying silence of a status asthmaticus chest in the ICU.
Precisely. But I have to issue a disclaimer before we begin. This is an exam preparation deep dive. We are basing our discussions strictly on the provided source texts. We all know clinical guidelines evolve rapidly, but in the exam hall, these standard texts are your Bible.
So, answer according to the book.
Answer according to the book, unless you have a landmark paper in your back pocket to justify a deviation.
Understood. Let's set the stage then. The exam usually begins with definitions. It sounds simple, but I've seen students stumble right out of the gate. We aren't just talking about asthma yet. We're starting with the umbrella category. Section 1, Introduction to Obstructive Lung Diseases. How do we frame this for the examiners to show we understand the physics of it?
Right. If the examiner asks, what is obstructive lung disease? Do not just list diseases. That's a classic mistake. You must focus on the physiological defect. The core concept is flow limitation. These are diseases characterized by an increase in resistance to airflow due to partial or complete obstruction at any level of the tracheobronchial tree.
So the problem isn't getting air in.
Exactly. It's getting air out.
And Robbins is very specific about the classification here. We refer to the big four.
Yes. In pathology, the big four are emphysema, chronic bronchitis, asthma, and bronchiectasis. You should list these confidently. It shows you've read beyond just the anesthesia texts.
But here is the pivot point. For the anesthesiologist, and specifically for this exam topic, we need to distinguish asthma from the rest, particularly from COPD. What is the single most important discriminator?
The magic word is reversibility. This is an exam tip right off the bat. If you say asthma is airway obstruction, you're only half right. You must say it is reversible airway obstruction.
So that's the key word, reversible.
Absolutely. COPD, which is a clinical syndrome often comprising emphysema and chronic bronchitis, is characterized by persistent airflow limitation that is not fully reversible.
So conceptualizing this for the Viva, asthma is a dynamic state. The airway clamps down, but it can open up again. COPD is more of a fixed structural change.
That's a perfect way to put it. And you need to be precise with the definition of asthma itself. It's not just wheezing. That's a symptom, not a definition.
Okay, so what's the full definition we should be giving?
Bronchial asthma is a chronic inflammatory disorder of the airways. This chronic inflammation causes airway hyperresponsiveness that leads to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or in the early morning.
You've used two key terms there, inflammation and hyperresponsiveness. We'll definitely need to unpack those.
We will. They're central to everything.
But first, let's touch on the epidemiology. Why does this matter to us as anesthesiologists? Is it just background noise, or is there a real safety implication?
It's a massive safety issue. I mean, the global burden is around 300 million people. It is likely the most common pulmonary comorbidity you will encounter in your day-to-day practice.
So we're going to see it all the time.
All the time. And Miller explicitly points out that about 9% of asthmatics may develop bronchospasm perioperatively.
9%. That's nearly 1 in 10. That is a statistically significant risk for every single list we run.
Correct. And intraoperative bronchospasm isn't a minor annoyance. It's not just a bitter wheezing. In severe cases, it leads to inability to ventilate, severe hypoxia, and potentially brain damage or death.
So this can be a true anesthetic catastrophe.
It can be. And you also need to be attuned to the concept of the silent chest, which signifies obstruction so severe that air movement is minimal. If you're waiting for a wheeze to diagnose severity, you might miss the patient who is about to arrest.
That is a terrifying concept, the silent chest. We will absolutely drill down into that later. But first, let's look at the exam paper itself. If I'm the student, what kind of questions am I anticipating?
You will see patterns. For short notes, they love mechanism-based questions like pathophysiology of asthma or equipment-based ones like capnography and bronchospasm.
Okay, short and focused.
Exactly. For the long 10 to 20 mark questions, expect a high-stakes clinical scenario. Discuss the anesthetic management of a case of status asthmaticus for emergency surgery.
The nightmare scenario.
The one that tests everything. And for the VIVA or OSCE, be ready to interpret flow volume loops or arterial blood gases on the spot.
Okay, let's tackle that first short note topic, section 2. The pathophysiological basis of asthma. This is the core of the exam, isn't it? If you don't understand the pathology, you can't justify your pharmacological choices later.
Absolutely. The most common mistake students make is thinking asthma is just bronchospasm, just muscle tightening. It's not. It is fundamentally a disease of chronic airway inflammation.
So the muscle spasm is just the symptom. The disease is the angry, inflamed tissue underneath.
Exactly. Even when the patient is asymptomatic, walking around feeling fine, their airway is infiltrated with mast cells, eosinophils, and T lymphocytes. This chronic state leads to what we call airway remodeling.
Remodeling sounds like a construction project, but in this context, I assume it's destructive.
It is maladaptive. It's the body trying to repair itself but doing a bad job. We see thickening of the subbasement membrane, hypertrophy of the smooth muscle, and hyperplasia of the mucus glands.
So the airway is literally changing its structure for the worse.
Precisely. This structural change makes the airway hyper-responsive.
Define hyper-responsiveness for me in an exam context.
Yeah.
How do I explain that to a junior colleague?
It is the tendency of the airways to narrow excessively in response to triggers that wouldn't affect a normal person. A little bit of cold air, a specific smell, or the mechanical touch of a laryngoscope blade that you or I would ignore causes a massive disproportionate reaction in an asthmatic.
A real overreaction of the
A
area.
huge overreaction. And then we have the mucus. This isn't just normal secretions, is it?
No, not at all.
Yeah.
The mucus plugging in asthma is nasty. It's thick, tenacious, and incredibly difficult to suction. Pathology texts like Robbins describe specific microscopic findings within this mucus.
Oh, this sounds like bonus points territory. It is. You have Kirschmann spirals, which are these little whorls of shed epithelium, and Charcot-Leyden crystals, which are composed of eosinophil proteins.
Those sound like incredible buzzwords for a pathology question.
They are gold medal details. Dropping Charcot-Leyden crystals into your answer tells the examiner you've read the pathology text. It's not just the anesthesia summary.
Okay, so Kirschmann spirals and Charcot-Leyden crystals. But what's the anesthetic relevance?
The clinical relevance is this, that inflammation makes the airway incredibly twitchy. Instrumentation, like putting in an endotracheal tube, is a potent trigger. You are essentially poking an angry bear.
An excellent analogy. Moving on to section 3. Immunological mechanisms. This is often labeled as exam gold. We need to understand the mechanism to understand the drugs we use.
You need to know that it is predominantly an Ig-mediated hypersensitivity, or type I hypersensitivity.
Walk us through the cellular level. Who are the players?
The star of the show is the mast cell. Think of them as sentinel cells embedded in the submucosa, just waiting. Exactly. In an atopic individual, someone prone to allergies, these cells are coated with IgE antibodies. When an antigen, say pollen, or a specific drug binds to that IgE, it causes cross-linking.
And cross-linking acts as the trigger, like turning a key in a lock.
A perfect analogy. It triggers degranulation. The mast cell essentially explodes, releasing a cocktail of preformed inflammatory mediators. The big one, of course, is histamine.
Which causes the immediate reaction we see on the table, the wheezing, the pressure going up.
Right. Histamine causes rapid bronchoconstriction and mucosal edema. That's the early phase. But you also have the synthesis of new mediators like the leukotrienes, which were formerly known as the slow-reacting substance of anaphylaxis.
That's a great piece of medical trivia. Slow-reacting substance of anaphylaxis.
It is. And it tells you what it does. Leukotrienes cause prolonged, sustained bronchospasm. They are much more potent and longer-lasting than histamine.
Okay, so that's the immediate problem.
Huh?
But you mentioned early versus late phase reactions.
Yes, and this is a crucial conceptual leap for the anesthesiologist, the early versus late phase reaction.
Why is this so clinically relevant for us?
The early phase happens in minutes. That's the immediate bronchospasm you fight during induction. But the late phase happens 2 to 8 hours later. This is caused by the recruitment of inflammatory cells like neutrophils and eosinophils into the airways.
So a patient could have a reaction in the OT, you stabilize them, everything looks good, you send them to the ward, and then
6 hours later, in the PCU or on the floor, they deteriorate. They might look fine initially, but crash post-op because of this late-phase inflammatory bloom.
that is a Viva trap right there.
Yeah.
Why did the patient deteriorate in the PCU despite a smooth emergence?
Exactly. If you can answer late-phase reaction due to inflammatory cell recruitment, you get full marks. It shows you're thinking beyond the immediate crisis.
Now, let's connect this to Section 4. Effects on lung mechanics. We talked about flow limitation. When the airways narrow, what happens to resistance?
It skyrockets. And for the exam, you need to quote Quazoo's law.
Oh, physics. Okay.
It's simple, but powerful. Resistance is inversely proportional to the radius to the power of 4 for laminar flow.
The power of 4. Let's do the
Yep.
math on that. If the radius is halved.
The resistance increases 16-fold. It's not a linear relationship. It's exponential.
16 times harder to breathe.
Exactly. And if flow becomes turbulent, which it often does in narrowed airways, the dependence is on the radius to the power of 5. This explains why breathing becomes such incredibly hard work. The patient has to generate massive negative pressure to pull air in and massive positive pressure to push it out.
And specifically, expiration is affected more than inspiration, correct? Why is that?
Yes. Inspiration is an active process. The chest wall expands and pulls the airways open through something called radial traction. Expiration, however, is normally passive. As the lung empties, the airways naturally narrow a bit. In asthma, this natural narrowing combined with the pathology, the swelling, the mucus, the spasm, leads to premature airway closure.
So the air gets trapped.
The air gets trapped. And this brings us to a critical concept, dynamic hyperinflation, or what we call Auto-PEEP.
Let's unpack Auto-PEEP. This is the term we hear in the ICU all the time, but explaining it physically can be tricky.
Imagine breathing in through a very thin straw. It's hard. Now imagine trying to breathe out through that same straw, but before you have finished exhaling, you are forced to take another breath in.
I'd still have air left in my lungs from the first breath. I wouldn't have time to empty them completely.
Exactly. Air goes in, but it cannot get out completely before the next breath starts. This is air trapping. The lungs get bigger and bigger with each breath. The functional residual capacity, or FRC, just keeps rising.
It sounds like it would increase pressure inside the chest quite a bit.
It does. It increases intrathoracic pressure. Now, think about the hemodynamics. What does high intrathoracic pressure do to the heart?
It acts like a tamponade. It squashes the great veins, reducing venous return to the right heart.
Correct. It decreases venous return, which decreases preload, which leads to hypotension. So, here is the clinical pearl. If you are ventilating an asthmatic and their blood pressure suddenly drops, you must immediately think of Auto-PEEP.
And the fix isn't fluids or pressors initially?
No, the immediate fix is to treat the cause, the trapped air. You disconnect the ventilator from the endotracheal tube. You allow a long apnea period. You might even gently push on the chest to help them exhale that trapped gas.
What happens when you do that?
You will hear a long hiss of air escaping, and you'll see the blood pressure come right back up. It's dramatic and life-saving.
That's a practical save-a-life tip. Disconnect and let them exhale. Now, Section 5. Clinical features of asthma. We know the classic triad, dyspnea, cough, wheezing, but you mentioned the silent chest earlier.
Yes. In the exam, they will ask, is the loudness of the wheeze a sign of severity? The answer is an emphatic NO.
Explain why. That seems counterintuitive.
Because to make a wheeze, which is a musical sound produced by turbulent flow through a narrow tube, you need airflow. In severe obstruction, there is so little air moving that there is no sound generation. A silent chest in a distressed tachypneic patient is a pre-terminal sign.
So silence is worse than noise.
Silence is terrifying. It means imminent respiratory arrest.
What about triggers? We know about pollen and dust. What about drugs? This is crucial for our history taking.
Aspirin and other NSAIDs are classic triggers. About 1% to 5% of asthmatics are sensitive. This is sometimes known as Samter's Triad, which is asthma, aspirin sensitivity, and nasal polyps.
What is the mechanism there? It's not IgE-mediated, is it?
No, it's not a true allergy. It's biochemical. NSAIDs inhibit the cyclooxygenase, or COX enzyme. This blocks the production of prostaglandins. However, the arachidonic acid precursor has to go somewhere.
So it gets diverted.
It gets shunted down the lipoxygenase pathway.
Which produces?
More leukotrienes. And as we know from our earlier discussion, leukotrienes cause potent, prolonged bronchospasm.
So as a rule, Avoid Toradol or diclofenac in these patients, unless you are absolutely certain they are not aspirin sensitive.
In any asthmatic with a history of nasal polyps or known aspirin sensitivity, absolutely avoid them. It's not worth the risk.
Let's talk investigations. Section 6, pulmonary function tests or PFTs. This is absolutely essential for the exam.
You must know the spirometric findings cold. The hallmark of any obstructive disease is a reduction in FEV1, the forced expiratory volume, in 1 second. The flow is slow.
And the FVC, the forced vital capacity, the total amount of air they can blow out.
It's usually normal or might be slightly reduced due to the air trapping we talked about. But the key number, the one the examiner wants to hear, is the FEV1-FVC ratio.
Okay.
In asthma and COPD, this ratio is reduced, typically less than 0.7 or 70%. A normal person can blow out most of their air in the first second. An obstructive person can't.
And how do we prove it's asthma and not COPD using just the PFT?
Reversibility testing. This is the gold standard for diagnosis. You do the spirometry, then you give a bronchodilator like salbutamol, wait 15 minutes, and repeat the test.
And what are we looking for?
If the FEV1 increases by more than 12% ND, more than 200 milliliters from the baseline, that is a positive test. It confirms reversible obstruction, which is the hallmark of asthma.
Okay, 12% and 200 milliliters. Got it. Now, for the visual learners, imagine the flow volume loop. You are at the whiteboard in the Viva. What are you drawing?
You draw the axes. With flow on the axis and volume on the x-axis, you draw the inspiratory limb, which is usually a nice symmetrical semicircle on the bottom. Then you draw the expiratory limb on top.
And for asthma?
The expiratory limb looks scooped out. It has a concave appearance. It starts with a sharp peak, but then the flow drops off very quickly and tails off as the airways collapse.
Unlike a restrictive disease.
Right. A restrictive disease, like pulmonary fibrosis, looks like a witch's hat. It's narrow because the volumes are small, but the shape is preserved. And it's tall because the flows can be high relative to the volume. Obstructive is scooped out.
Section 7. ABG changes in asthma. This is an exam favorite. How does the ABG change as an asthma attack progresses from mild to severe?
This is a classic progression that you must know. In early or mild asthma, the patient is anxious, they feel short of breath, so they hyperventilate. They're breathing fast, so what happens to their CO2?
They blow it off. So hypocapnia, which leads to a respiratory alkalosis.
Correct. And usually mild hypoxemia because of some VQ mismatch. Now, as the attack gets more severe and the patient gets tired, remember, breathing through a straw is exhausting work. The respiratory muscles begin to fatigue. The rate might stay high, but the tidal volume drops. The CO2 starts to rise. It returns to normal.
Wait, normal CO2 sounds good. If I see a PACO2 of 40 mmHg on an ABG, I'm usually pretty happy.
No, that is the trap. A normal PACO2, say 35 to 45 mmHg, in a tachypneic, panting, distressed asthmatic is a huge danger sign.
Why?
It implies that they can no longer maintain the work of breathing needed to clear the CO2. They are tiring out. They are failing.
So if I see a normal CO2 in a distressed asthmatic, I shouldn't be reassured. I should be worried.
You should be preparing for intubation. It signals impending respiratory failure. The next stage is hypercapnia, a high CO2, which causes a respiratory acidosis, and severe hypoxemia. If you wait for the CO2 to be high, you have waited too long.
Let's move to Section 8, preoperative evaluation. A patient comes to your clinic with a history of asthma, scheduled for elective surgery. What are the high-yield questions?
History is absolutely key. You want to know the frequency of their inhaler use. Are they using their rescue inhaler daily? That's a bad sign.
What else?
You need to know about their history of hospitalizations. Have they ever been admitted for asthma? Ever been in the ICU? And the most critical question, have they ever been intubated for their asthma?
Why is the intubation history so important?
If they've been intubated for asthma before, they are, by definition, a high-risk patient. It suggests their disease is capable of becoming life-threatening very quickly. Also, ask about recent upper respiratory infections, or URIs.
Common cold.
Exactly. A URI increases airway reactivity for weeks. Some texts say up to 6 weeks post-infection.
That's a long time. If they have a cold, do we cancel the surgery?
For elective surgery, yes. The rule of thumb is that elective surgery should be done when the patient is at their baseline, symptom-free. If they are actively wheezing in the pre-op bay, you do not induce, you postpone. If they had a URI last week, you postpone if possible.
What about smoking cessation? Always a good idea, but what's the timeline?
The longer the better. Ideally 4 to 8 weeks.
What if they stop just 48 hours before? Does that do anything?
It helps with carboxyhemoglobin levels. It shifts the oxygen dissociation curve back to the right, which improves oxygen delivery to the tissues. but it doesn't do much for airway reactivity or mucus clearance. In fact, sputum production might increase initially as the cilia start to wake up and clear out the gunk.
So 4 to 8 weeks is the real target for pulmonary benefit.
Yes, that's when you start to see restoration of mucociliary transport and a reduction in post-op pulmonary complications.
Let's look at Section 9, risk stratification. How do we put all that information together to decide who is going to have bronchospasm on the table?
The main predictors are a recent URI, as we just discussed, active smoking, and the type of surgery and airway device.
So instrumentation of the airway matters a lot.
It's a huge factor. An endotracheal tube, an ETT, is much more stimulating to the trachea than a laryngeal mask airway, or LMA. Also, be aware that well-controlled asthma carries a risk that's pretty similar to non-asthmatics. It's the poorly controlled or symptomatic patient who is in the danger zone.
That leads us perfectly to Section 10, choice of anesthesia.
If you have a choice, regional anesthesia is the gold standard for an asthmatic patient.
Why? What's the advantage?
It's simple. You avoid putting a tube in the trachea, you avoid that direct mechanical stimulation of the twitchy airway, you bypass the main trigger entirely.
But there's a caveat, right? We can't just do a high spinal block and relax.
Correct. You have to be careful. Avoid high blocks, generally above the T4 dermatome. That might compromise the accessory muscles of respiration. An asthmatic needs their intercostals and abdominal muscles to actively exhale against resistance. If you knock out their intercostals with a high spinal, they might feel dyspneic even if their oxygenation is perfectly fine.
But sometimes we have to do general anesthesia, laparoscopy, for instance, or major abdominal surgery.
Right. And if you must do GA, the goal is deep anesthesia. You need to completely suppress those airway reflexes before you touch the airway with a laryngoscope or a tube.
Okay, let's talk about Section 11, pre-medication strategies. How do we set them up for success before they even get to the OR?
First, anxiety triggers bronchospasm. It's a physiological response via the parasympathetic system. So anxiolysis with something like a small dose of midazolam is very useful.
And their inhalers, do they take them on the day of surgery?
Absolutely. They should continue all their regular inhalers, including their steroids and long-acting bronchodilators, right up to the morning of surgery. We often give a prophylactic nebulization with salbutamol in the pre-op area as well.
And what about steroids, the systemic ones?
This is key. If they are on chronic systemic steroids, their own adrenal axis is suppressed. You must give them a stress dose of steroids, usually hydrocortisone 100 milligram IV at induction, and then continue at post-op.
And what if they're not on chronic steroids, but they're actively wheezing before an urgent surgery?
In that case, we might start a short course of oral steroids for 3 to 5 days pre-op to really calm the inflammation down before the surgery date.
Now, the moment of truth. Section 12, induction and airway management. We want a smooth, gentle induction. What drugs are we reaching for?
Propofol is a great choice. It has mild bronchodilating properties, and it suppresses the laryngeal reflexes very well. It's a very smooth induction.
What about ketamine? I always hear about ketamine for asthmatics.
Ketamine is the theoretical exam answer for the actively wheezing patient. It is an excellent bronchodilator. It works via a sympathomimetic action. It increases circulating catecholamines, which relax the bronchial smooth muscle. It's the agent of choice in a hypotensive asthmatic or someone in the middle of a severe bronchospasm.
Are there any downsides to ketamine?
Yes. The big one is increased secretions. You might need to give an antisalagod like glycopyrrolate alongside it to keep the airway dry.
And what do we avoid for induction?
The classic one to avoid is thiopentone. Historically, it's associated with histamine release. In an exam, if you suggest thiopentone for an asthmatic, you might get a frown from the examiner.
Even if the evidence is a bit weak.
Even then, why take the risk when propofol exists? It's about choosing the safest possible option.
Airway device. You mentioned an LMA is better.
An LMA sits above the glottis. It doesn't stimulate the trachea itself, so it is much less stimulating and preferred if there is no contraindication, like a high risk of aspiration, or if you need high ventilatory pressures.
But if we need an ETT, for a lap coal, for example,
then you must ensure the patient is deep. I can't stress this enough. Deep volatile anesthesia, or you can use IV lidocaine, about 1.5 milligigagrams, given 90 seconds before you intubate to blunt the airway reflexes. Do not intubate a light asthmatic. That is asking for disaster.
Once the tube is in, we have to ventilate them. Section 13, intraoperative ventilation strategy. This is marked as very high yield.
It is. The entire strategy can be summed up in 3 words. Avoid air trapping. Prevent that auto-PEEP we talked about.
So how do we set the ventilator to do that?
We need to give them a long time to exhale. Remember, their expiration is prolonged and difficult, so we use a low respiratory rate, maybe 6 to 10 breaths per minute, and we deliberately prolong the expiratory time.
So the IE ratio.
Instead of the usual 1.2, we go for 1.2.5, 1.3, or even 1.4 in severe cases. We want the expiratory phase to be long enough for the expiratory flow to return to zero before the next breath is delivered.
But if we breathe them that slowly, their CO2 will rise.
And that is okay. That is the concept of permissive hypercapnia. We accept a higher CO2 as long as the pH stays above roughly 7.2 in exchange for lower airway pressures and avoiding barotrauma or the hemodynamic collapse from Auto-PEEP. We prioritize lung mechanics over blood gas chemistry.
And the tidal volume.
Moderate, 6 to 8 millikilograms of ideal body weight. Don't use large tidal volumes that could overdistend the lungs.
Section 14. Anesthetic drug considerations. We're in the maintenance phase of anesthesia. Which gas are we using?
Sevoflurane. It's an excellent bronchodilator, and it's non-irritant, it's sweet-smelling. It is the agent of choice for maintenance.
What about desflurane?
Absolutely not. Desflurane is pungent, it irritates the airway and can cause coughing, laryngospasm, and bronchospasm. Avoid it in asthmatics. It's a key drug to avoid.
And muscle relaxants. We've induced, now we need to keep them relaxed.
Avoid the histamine releasers. That means atracurium and its cousin mivacurium are out.
So what are the safe choices?
Rocuronium, vecuronium, or cisatracurium. They are historically very safe regarding histamine release. Stick to those.
Analgesics. Fentanyl versus morphine.
Fentanyl and its derivatives are safe. Morphine is a known histamine releaser, so in the exam, you say you will avoid morphine.
Okay, we're in the middle of surgery. We've done everything right, but suddenly the peak pressures go up, the alarms are blaring. Section 15. Recognition of intraoperative bronchospasm.
Clinically, you might hear a wheeze with your stethoscope. But remember, with the noise of the OT and the surgical drapes, you might miss it. The most reliable sign is on your monitor. Look at the capnograph.
The waveform.
Yes, you will see a classic shark fin pattern.
Describe that for the listener who has to draw it in an exam.
Normally, the expiratory waveform is a nice square box. You have a sharp upstroke, a flat plateau, and a sharp downstroke. In bronchospasm, the upstroke, which is phase 2, becomes slow and slurred because of the obstruction. And the alveolar plateau, phase 3, slopes steeply upward because the alveoli are emptying at different rates.
So it looks like a shark's dorsal fin.
Exactly. Pointing to the left on most monitors, it's an unmistakable sign of expiratory airflow obstruction.
And we need to verify this with the ventilator pressures.
Yes. You will see a high peak inspiratory pressure, PIP. But, and here is the key discriminator for the VIVA, the plateau pressure, P-plat, will be normal or only slightly elevated.
Why is the plateau pressure normal?
Because plateau pressure reflects the compliance of the lung parenchyma and the chest wall, the static compliance. In asthma, the compliance of the lungs themselves is generally okay. The problem is the resistance in the conducting airways.
So, to summarize for the exam.
A high peak pressure with a normal plateau pressure means a resistance problem. Think asthma, a kinked tube, or a mucus plug. A high peak pressure with a high plateau pressure means a compliance problem. Think pneumothorax, pulmonary edema, or abdominal insufflation.
That is a crucial distinction. It helps you build a differential diagnosis in seconds.
It helps you rule out a life-threatening pneumothorax very quickly.
So we have identified bronchospasm. The shark fin is there. The pressures are up. Section 16, management of acute bronchospasm. Give us the examiner-safe algorithm, step by step.
Okay. Step 1. Deepen anesthesia. Light anesthesia is the most common cause of bronchospasm under GA. Turn up the sevoflurane to 3 or 4%, or give a bolus of Propofol, step 2, 100% oxygen. And switch to manual ventilation. Get your hand on the bag. You can feel the compliance and resistance much better than the machine can tell you. It also helps you rule out a ventilator malfunction.
Step 3, pharmacology.
Beta-2 agonists. Give salbutamol. You can puff it directly down the ETT using a specific adapter, or use a nebulizer in the breathing circuit. Give 6 to 8 puffs and assess the response.
Step 4.
Add anticholinergics like ipratropium bromide. It's often given together with the salbutamol for a synergistic effect on bronchodilation.
Step 5, if things aren't improving.
IV steroids, hydrocortisone, 100, 200 milligram, or dexamethasone. Remember, this takes hours to work, so it won't fix the spasm now, but you must give it early to treat the underlying inflammation and prevent that late-phase reaction.
Step 6.
5V magnesium sulfate. 2 grams infused intravenously over about 20 minutes.
How does magnesium work here?
It acts as a smooth muscle relaxant. It interferes with calcium uptake and signaling in the bronchial smooth muscle cells, causing them to relax. It's very effective in severe refractory cases.
Is there a role for epinephrine?
Yes, in refractory, life-threatening cases. If the blood pressure is dropping and you can't break the spasm, give low-dose IV epinephrine.
Yeah.
You can give it in small boluses of, say, 10 to 20 micrograms at a time or as a continuous infusion.
And ketamine.
If you haven't already used it for induction, a bolus of ketamine, say 0.5 milligram, can also help break the spasm.
The surgery is done. You've managed the spasm. Time to wake them up. Section 17 and 18. Postoperative complications and management.
The main post-op complications are a recurrence of bronchospasm, especially during extubation, hypoxia due to ongoing VQ mismatch, and atelectasis. Those mucus plugs can easily collapse segments of the lung.
And the extubation itself, this is always a tense moment.
It is. This is the great debate. Deep versus awake extubation.
So deep extubation means taking the tube out while they are still deeply anesthetized.
Yeah.
In Weddell's stage 3, so they don't cough on the tube.
Right. It's elegant when it works. No coughing, no bucking, no bronchospasm triggered by the tube. But you lose your airway protection immediately. If they vomit or have a lot of secretions, they can aspirate. It requires an expert hand and a guaranteed easy airway.
And awake extubation.
This is safer from an aspiration point of view, but they will almost certainly cough on the tube, and that coughing is a powerful trigger for bronchospasm.
So what's the exam answer? There's no perfect choice.
The safe answer for a generalist and for the exam is usually awake but smooth. This is the middle ground. You utilize ibuprofen or small doses of opioids to suppress the cough reflex, but you ensure they are fully awake, following commands, and breathing adequately before you pull the tube. However, you should mention that deep extubation is an option in carefully selected patients.
Post-op pain control matters too, I assume.
Absolutely. If they are in pain, they splint. They don't take deep breaths. That worsens atelectasis and mucus plugging. Epidurals are fantastic for thoracic or major abdominal surgery in asthmatics because they provide excellent pain relief without respiratory depression.
Let's briefly touch on Section 19. ICU management for severe asthma or status asthmaticus. When do we decide to intubate a patient with severe asthma in the ICU?
It's a last resort. We try everything else first. BiPAP, high-flow oxygen, continuous nebs. The indications for intubation are a rising PaCO2 indicating fatigue, a deteriorating level of consciousness, or, of course, cardiorespiratory arrest.
But ventilation in status asthmaticus is famously dangerous.
Extremely. The risk of barotrauma, like causing a pneumothorax and severe hypotension from Auto-PEEP, is very high. We use the strategy of controlled hypoventilation. We deliberately allow the CO2 to rise, permissive hypercapnia, to keep the airway pressures down. We prioritize keeping the plateau pressure below 30 centimeter H2O over achieving a normal pH.
And constantly watching for that Auto-PEEP.
Constantly. If they suddenly become hypotensive on the ventilator, your first move is to disconnect the circuit and manually decompress the chest.
Before we wrap up, let's hit Section 20, comparison tables. These are high yield for the Viva Voce. Let's do a quick fire round, asthma versus COPD.
Age of onset. Asthma is usually childhood or early adulthood. COPD is midlife or later.
Asthma is associated with allergy, atopy, eczema. COPD is overwhelmingly associated with smoking.
Asthma shows significant reversibility with bronchodilators. COPD shows minimal or only partial reversibility. DLCO, diffusion capacity. This is a key differentiator. It is normal in pure asthma because the lung parenchyma, the alveoli, are intact. It is decreased in emphysema-predominant COPD because the parenchyma is destroyed.
That DLCO point is a great Viva nugget. It shows a deep physiological understanding.
It separates the students who have read deeply from those who have just skimmed the summary chapter.
Let's review Section 21. Common exam questions and Viva traps. We've covered a few. Trap 1. Is wheezing a sign of severity?
No, a silent chest is far worse.
Trap 2. A normal ABG in a panting asthmatic.
It's a sign of impending failure, not stability.
Trap 3. Using atracurium for muscle relaxation.
Don't say it. It's a known histamine releaser. Stick to rocuronium or vecuronium.
And the examiner's favorite waveform.
The capnograph in bronchospasm. The shark fin. Be able to draw it and explain why phase 2 is prolonged and phase 3 is upsloping due to uneven alveolar emptying.
Section 22. Diagrams. In a written exam, what should we definitely draw?
Definitely draw the flow volume loop showing the scooped-out appearance of obstruction. And for a management question, draw the bronchospasm management algorithm as a flowchart. It saves time, it's clear, and it looks professional.
Let's summarize. Section 23. Summary and exam conclusion. Give us the final high-yield recap. The take-home points.
Okay. 1. Asthma is fundamentally a disease of inflammation and hyperreactivity. It's not just about muscle spasm. 2. Preoperative optimization is mandatory before any elective surgery. Symptom-free is the goal. 3. Avoid histamine-releasing drugs like thiopentone, atracurium, and morphine. 4. Deep anesthesia before any airway manipulation is non-negotiable. Light anesthesia is your enemy. 5. And finally, permissive hypercapnia is your friend when ventilating a severe asthmatic. Prioritize low pressures over a normal CO2.
That is a solid foundation. If you can articulate those 5 points clearly, you're in a very good position.
Mastering this topic gives you confidence. It's a common clinical case, but when managed poorly, it's a nightmare. When you manage it well, it's smooth sailing.
Good luck to everyone preparing for the Gujarat University exams, or for any anesthesiology board exam for that matter. You have the tools now.
My advice, go practice drawing those flow volume loops in the shark fin capnograph right now.
Yeah.
Don't wait. Get it into your muscle memory.
Next time, we tackled the cardiac risk index. Until then, keep diving deep.